So what is wireless? It's really like software, if you will. And it's a good analogy. It's a loan, it's a component, it's a function, it's monitoring, it's dispensing, it's sending a signal. It can be invasive. It can be all these things. And you have to remember, FDA still doesn't have a cohesive policy on computer software. Senator Grassley sent them a letter about 6 months ago saying, what are you doing on computer software? Now that's, in one sense, shocking, but it's a reality of FDA doesn't really want to get out there and get in trouble and doesn't want caught. So this is what we have to look at. Now they've also got this home use initiative, requirements for wellness applications, distinctions between devices and equipment that simply transmit, secure transmission of wireless, labeling of wireless. They're not sure what to do. I mean, they're living in this time of the 50s and 60s. So we have a situation where FDA is just trying to avoid making decisions and being cautious, not wanting to make a mistake, and the industry moving forward. They've looked at several of these, okay? And here's a list, brief list of some of these things they've looked at. Devices showing tracings, transmission of information. And you know, FDA is cautious, for example, the PACS devices. You know, if you give 3 pathologists a slide, you'll get 3 answers. If you send, you send it over a wireless, how accurate can it be? So FDA has this historic caution. You never go wrong. You never bet against FDA being cautious. And to me, one of the most difficult situations or dilemmas, I ran into a situation analogous to this, where this company put an app on a smartphone. FDA said, take it off. FDA said, well, we think you can do a 510K. They submit the 510K. FDA said, no, there's no antecedent device. You can do a PMA. And I've been on phone calls with FDA where I've had to fight it out with this LA district and others, and they just come on strong to people. But no one's really figured out all the intricacies because there is liability. You know, I was in San Francisco for the JP Morgan, and I just envisioned, you know, I've got an app, and I call my doctor, listen to my heart, and the AT&T system cuts out. You know, who's liable for the problem? But a lot of things have to be worked out. So what's the first mover advantage? Because the industry is not going to stand still. I think the most important thing is don't let your first move be into a morass where FDA can catch you and will never let you out. I think what we have to look at is what, from an eagle's nest view, what do you see in Washington? What are your opportunities? And I think we'll get into today meaningful use. That's really part of the CMS process. You're going to start paying for metrics, electronic medical records, electronic health records. To me, the next one is system support, clinical trials and pharmacovigilance. I have clients running clinical trials where they'll send IMs to patients. You're due today to come in for blood work. You're due for this. You're due for that. So you're using wireless technology in a way that builds confidence, that FDA sees, that builds confidence in its robustness. Pharmacovigilance, we had the change in law in 2007 on the drug side to increase safety. So you're able to use, in my view, wireless information to collect pharmacovigilance data. They're REMS, the risk evaluation and management strategies. If you can begin to use wireless technologies in those situations where you're outside the scope of the pre-market approval process of FDA, again, they build confidence in FDA in the technologies. Interoperability, key issue for CMS. You can't underestimate this. I represented a chain of hospitals that acquired all these doc practices a decade ago, and none of the doc practice computers work together. So they were trying to get a survey of how many patients were in cancer clinical trials quarterly. So every quarter they had to get on the phone and call every doc and check the numbers because the computer systems, as they rolled them up, with the docs didn't work. So you have to look at that element of wireless. Now, how are you going to get paid? You know, when you always have to follow the money. And my concern is confronting payers directly in the federal government. I don't think that's going to work. They're cautious, they're broke, the states are broke. So my strategy is the following. There are a number of payment plans and programs. Part C plans, prescription drug plans, are Medicare Advantage. Their goal is to keep people healthy because they've capitated the drug use with the health care and hospital costs. They're able to pay for certain things to keep people healthy. A patient, or insured to them, is an asset. And as long as they can keep diabetics healthy, as long as they can keep you out of the hospital, you're an asset. When you're a patient, you're a liability to them. So I think beginning a dialogue with the Part C plans to use wireless technology for healthcare is a vital first step. Part D plans are competitive plans for drug programs for the elderly. In order to compete against each other, they are able to give valuable assets. Wireless technology devices, in my view, can fit in there. That they can give you a phone, they can give you wireless technology that can keep track of what you're doing. Medication therapeutic management programs are the rage right now in Part C and D. How do we keep you healthy? There's money for this. The pharmacist, the APHA wants the pharmacist to control this, but this is another arena for wireless technology. And the supplemental benefits. You can get supplemental benefits with a number of Part D plans, and I think you look at dealing with those plans. In this way, you're building a reputation for credibility, robustness for your technology without asking directly CMS to pay for your technology. I think the states and the Medicaid programs, who are also broke, are interested in these things. And finally, veterinary uses are outside the scope of pre-approval from FDA. So you can always deal with the animals, and you can always look at things abroad. But I think that's a little riskier from the standpoint of bona fides. So that's the general framework that I think the opportunities are there. I think you have to keep moving forward in the short term until FDA gets its act together and decides what's bona fide and what's not. I believe this is a practical approach for the next 2 to 3 years. Remembering that in 2012, FDA, they're going to have to reauthorize the user fees for medical devices. That process is political. There'll be many stakeholders involved. It's an opportunity to get your voice heard. It's an opportunity to create a unique process for wireless. Because the other thing you have to remember is big people like regulation because they can absorb the costs. So you have to be very careful about trying to get your voice heard, getting in there. And, you know, you're heard here. We just did a fundraiser last week for Kevin McCarthy, who's the House Majority Whip. And he's heard about the problems that FDA is causing in the LA region. So the concerns are bubbling up. It's just now is the opportunity to begin the process, to keep going, use these multiple facets and opportunities to keep going until you can really develop FDA approval processes that are robust and reproducible, as well as, you know, getting paid for them. So with that, I'm going to introduce someone who's really into the nuts and bolts of dealing with the whole process, and that's Rick Strobridge, who's the CEO of Entra Health Systems, who's working on MyGluco Health Diabetes Management Technology, which really deals with a lot of these elements. So Rick, why don't you come on up?